हो गई अजीत सर बात।
A very good morning to one and all. I am Dr. Uttara Mohan from IAP Digital Media team hosting this webinar. Uh, First of all, I would like to wish everyone present here a happy World Physiotherapy Day. On this special occasion, we have this webinar being organized by IAP Jharkhand branch on the theme Rehabilitation in Long COVID. We are streaming live on IAP India YouTube channel. I request all to subscribe to this channel to get a regular notification of our upcoming webinars. Do subscribe and watch our webinars we have for this whole day and the next couple of days until Sunday on the occasion of World Physiotherapy Day. Now I request the Jharkhand team to please take over.
संध्या मैम स्टार्ट करो।
Good morning to all dignitaries, guests and participants. Myself, Dr. Sandhya, welcome you all on virtual celebration of World Physiotherapy Day organized by IAP Jharkhand branch. A very happy Physiotherapy Day to you all. Our today's theme is rehabilitation and long COVID. To start the program, I would like to invite Dr. Ajit Kumar, President of IAP Jharkhand, for the welcome speech. Over to you, sir. Dr. Ajit Kumar. Over to you, sir, Dr. Ajit.
Thank you, Sandhya madam. Good morning, everyone. On behalf of the Indian Association of Physiotherapists, Jharkhand branch, I welcome Chief Guest of the event, Sri Uma Shankar Singh, IS, Mission Director, NHM, Department of Health and Family Welfare, Government of Jharkhand. The guest of honor, Dr. Vijay Misra, Medical Director and Director Critical Care, Medica Hospital, Ranchi. Our special guest, Dr. Sanjeev Kumar Jha, National President, IAP. And our speakers, Dr. K.M. Annamalai, General Secretary, IAP, as well as HOD, Apollo Hospital, Ahmedabad. Dr. Sunit Wagre, Assistant Professor, College of Physiotherapy, Nizam Institute of Medical Science, Hyderabad. This year, the theme of World Physiotherapy is rehabilitation and long COVID. We celebrate World Physiotherapy Day on this day to create awareness and discuss various new research and academics for the development of the physiotherapy profession. We are in the middle of this pandemic where COVID affects our lungs and decreases lung capacity. Many physiotherapists work day and night in critical care setup and perform chest physiotherapy to save many COVID patients. We salute those fighters who lost their lives while serving mankind. Let us keep 2 minutes of silence for those departed souls. Okay, thank you. I welcome all participants for this virtual event. These lectures on the topic rehabilitation and long COVID will help them in their practices and they will be able to implement it on COVID patients. I am thankful to our mission director that only NHM is having contractual government physiotherapists in Jharkhand and they work very well in COVID ICU and post-COVID care. I'd like to request our chief guest to look after their salary grievances in contractual service and also recruit physiotherapists in PSC and CSC level for benefits of the poor and needy patients of the state. Thank you all.
May I invite our special guest, Dr. Sanjeev Jha, National President of IAP, founder of Center for Chronic Disease and Research, Principal of RD Medical College, Ujjain. He is nationally and internationally recognized as an expert in the field of physiotherapy and a great entrepreneur. Over to you, sir, Dr. Sanjeev Jha.
Thank you, Dr. Sandhya, Dr. Ajit Kumar, Dr. Rajiv Ranjan, and all the Jharkhand branch CC members. I'm very privileged to be here, and it's a very honor. And let me, from the side of the Central IAP to all the participants in the all Jharkhand branch, let me say a very prosperous and very happy World Physiotherapy Day. Now, when I'm saying this very happy World Physiotherapy Day, let me welcome also on this occasion Mr. Umasankar Singh, IS, and then Mr. Vijay, Dr. Vijay Misra, Dr. K. M. Annamalai, our General Secretary, Dr. Suneet, our Assistant Professor, who is going to talk on this day, on this topic, and all the Jharkhand branch. Let me tell you that we are, even if we are in pandemic, we have lost many things, but you know, मैं अक्सर कहता हूँ कि कोई भी अंधेरा ऐसा नहीं हो सकता जो उजाले को ढक ले. तो उजाला जरूर आता है और मैं ये महसूस करता हूँ और ये मैं मानता हूँ कि इस अंधेरे और इस टफ पेंडेमिक टाइम में भी जब हम लोग लॉन्ग कोविड और कोविड रिहैबिलिटेशन की बात कर रहे हैं, हम लोग वी आर ब्लेस्ड दैट आफ्टर 60 years of struggle हम लोग नेशनल मैं देख रहा हूँ. Hello, are you able to hear me?
Yes, sir, now you're audible. थोड़ा बीच में प्रॉब्लम हो रहा था सर, वो आवाज करके.
So there is problem with the net. So I just want to say that from the side of Central IAP, we are always there for upliftment of the physiotherapy profession. And let me tell you that with our 400 together, with a teamwork, one decade will be a strong decade for physiotherapy.
सर का कनेक्शन शायद लॉस्ट हो गया। सर क्या हम लोग इसको आगे बढ़ा सकते हैं? अजीत सर।
आगे कर लो संध्या।
Okay, sir. Thank you. It is my honor to invite our guest of honor, Dr. Vijay Mishra, Medical Director and Director of Critical Care of Medica Hospital, Ranchi. He has done a tremendous job in COVID period by saving thousands of lives, irrespective of his own life. Over to you, sir. Dr. Vijay Mishra, sir.
Good morning, everybody. First of all, let me thank Jharkhand chapter of IAP, Dr. Ajit Kumar, for inviting me on this platform. I'll start by welcoming the National IAP President, Dr. Sanjeev Kumar, our Chief Guest, Mr. Umar Shankar Singh, IAS, who's the Mission Director of National Health Mission in Jharkhand. Dr. Rajiv, who's a close associate, and the two speakers who will be talking about the rehabilitation and long COVID. Thank you once again. This and I congratulate you all on the World Physiotherapy Day. मैं अपने स्पीच को both English and Hindi में mix करके रखूँगा. The way physiotherapy works, it's never using one modality. You use multimodal approach to cure your patients. The role of physiotherapy when we were fresh medical graduates, when we had just graduated from medical college or we were doing our post-graduation, we did not even know much about physiotherapy. So that is, I'm talking something about around 15 years ago, or 15 years ago. But today, no aspect of healthcare, be it acute healthcare, be it critical care, be it ward care, be it home care, no aspect of healthcare is untouched by physiotherapy. So essentially what it tells us that physiotherapy is a branch of healthcare, is a branch of medicine that is required at all stages of the care of a sick patient. And thus becomes the role of a physiotherapist so much more important and relevant when you are caring for a sick one. Especially during COVID, the hospital that I work in has got a big department of physiotherapy. There are 7, 8, or 10 young physiotherapists. And trust me, I always used to think that it's us doctors who cure the patients and we are the real heroes. But no, we are not. We were prescribing medicines, we were reading literatures, talking to families, getting all the limelight. We were the ones who were talking to media in the newspaper, to the family. But the job that the physiotherapists were doing by the bedside of a COVID positive patient with a bad pneumonia, with a bad ARDS, is tremendous, and hats off to you guys. Also, there were a lot of debate about not engaging into procedures which were aerosol generating, thus exposing your own healthcare staff to the risks of COVID. But what I really saw is that taking all the precautions, not being too worried about themselves, these physiotherapists, they did go close to the patients on an IV, patients on ventilator, patients requiring awake proning, and we all know how awake proning was the word that everybody was using right from home to ICU. So the role played by the team of physiotherapy, the physiotherapists, special people like yourselves, was actually as important as the role played by the nurse or by the doctor. And more so, the acute wave has gone. Patients Unfortunately, those who did not survive is a sad thing. But those who survived, I will not be able to put a number to it, but majority of them, a large number of them, were left with post-COVID complications or a very delayed recovery from the acute infection, which is what we call as long COVID. Now, these patients, they do not require hospital. They do not require any medicines. What they require is they require rehabilitation. And rehabilitation is a process, as we say, it's rehabilitate. So you're going back to your own habits, your habitat. So it's always a long drawn process. It's a process which requires a lot of patience. It's a process which requires a lot of perseverance, motivation. So here comes the role of people like yourselves to complete the job that was started in a hospital, but now that has to be completed, given a final shape by yourselves. And even today, like I get a lot of follow-up patients coming with कि अभी भी सर एक भी सीढ़ी नहीं चढ़ सकते, थोड़ा भी दूर जाते हैं तो दम फूलने लगता है, थक जाते हैं. So what do I do in this, to be honest? Now it is that special role that you people play will come into picture, and that's where this pandemic, even though we lost few people, but has taught us so many things. And one of the things that I will request to people in this group today is that, yes, physiotherapy is not just breathing exercise or limb exercise or muscle building exercise. I will emphasize on it and request yourselves to also work on motivating the people, to brain building, the confidence building. Because a lot of people don't do physiotherapy because they're just too demotivated. They think कि अब हमारा तो कुछ नहीं हो सकता है, हमको तो ऐसे ही रहना है. Right? So that mental strength is probably one of the most important things that can only be given by the family members and the physiotherapist who visits the patient or whom the patient sees almost on a daily basis. So yes, it's a long path ahead, but you are the people who will do it, and you are the ones who are specialized, trained, motivated, and committed to do this. And once again, thank you very much, and I wish you all the best on this World Physiotherapy Day, and thank you very much.
Thank you for your motivational words, sir. Thank you very much. Now we'll request our chief guest of event, Sri Uma Shankar Singh, an IAS officer, Mission Director, NHM, Health and Family Welfare Department, Government of Jharkhand. Over to you, sir.
He is not connected. So.
Okay. So shall we move, sir? With the lectures?
Yeah, lectures. We will start lectures.
Okay. Now we are going to start our lecture session on rehabilitation and long COVID. The topic will be enlightened by Dr. K.M. Annamalai, General Secretary of IAP and HOD of Apollo Hospital, Ahmedabad, one of the finest physiotherapists of our country. He has received various awards from medical institutions for his teaching abilities. So now Dr. K.M. Annamalai, over to you, sir.
Yeah. So can you hear me?
Yes, sir, you are audible.
Yeah. So very good morning to everyone, and the great the year ahead of, I think the golden era is going to start for us, and wish you the great happy World Physiotherapy Day to everyone. And I think the President sir has spoken well, and I was just listening, and also the doctors have also has spoken very well regarding what is a post-long COVID ICU management. So right now, today, I'm going to, I would like to share some things regarding the ICU management in long COVID. So first, let us start with a global perspective. In global perspective, if you see the global situation, according to September 3, which is the last data which I fetched, it is around 218 million, more than 218 million are confirmed case, whereas the 4.5 million are COVID-related death is been in worldwide. Whereas the situation around the globe, if you see, the America is having maximum, whereas the Europe is next, and Southeast Asia is going to be the third place, where that means totally right now in situation is concerned. If we are just going for a vaccination, how much we have done is, it is more than 5 billion vaccination has been done up to August 31st, 2021 is updated data. Let us now see the Indian perspective, because now we have seen the global perspective. Let us see the Indian perspective. It is more than 32 million cases have been confirmed, and more than 4 lakh COVID death has been reported officially, and more than 15 million people have been fully vaccinated, which is 11.3 population of the country, which is fully vaccinated. So let us put it the COVID in a nutshell. It is a beta coronavirus, which is a RNA protein shell, and the protein is going to attach with the ACE2 receptors. The RNA virus enters through the cell and dividing into in an incubation period of 2 to 14 days. And the contagious range is around 8 to 37 days. It can be contagious. That means it can be able to spread everywhere. The most common symptoms which we come across during those days and nowadays, and we are awaiting days to become fever, fatigue, cough, shortness of breath, weakness, weight loss, headache, diarrhea, nausea, vomiting, palpitation, anxiety, depression, and pain. So these are all the different kind of symptoms which we come across. And we are dividing the severity of illness into 3 categories: mild to moderate symptom, and 80% they will be get all right in home quarantine only. And severe symptoms, 15%, they need a hospital support and oxygen support. And critically population, that is ICU requirement, is 5%. So we are dividing into mild, moderate, severe. So according to the Ministry of Health India, there was a beautiful study, which is a retrospective study. It shows that men is affected more than the women, and especially the people who are more than 70 years age. The specific comorbidity in Indian conditions, in Indian perspective, what has happened means the hypertension, obesity, diabetes are the 3 major chunk where these comorbidities contribute the big host for the disease to become a guest. And apart from that, if you see the effect of the impact of COVID-19, it is created finally the patient must be reaching to ARDS, acute respiratory distress syndrome, ICU acquired weakness, post-intensive care syndrome, and impact the function of cardiovascular, respiratory, and gastrointestinal, even sometimes neurological symptoms. See, what is the beauty of this disease means the impact is a normal pneumonia is different from COVID pneumonia. If you go through the CT scan, actually in normal pneumonia, the patches comes from central to peripheral. Whereas here there is a loss of elasticity, and due to ACE receptors present in the peripheral area, it is moved from peripheral to central. That is the beauty of the difference of COVID-19 pneumonia has to be fibrosis or interstitial lungs disease should be differentiated from other diseases. So it's a different kind of pathophysiology. The persistent symptom of COVID-19. See, what is COVID-19? Long COVID-19. Why the term they have given a long COVID-19? Because here, once a COVID-19 has been completed, that virus incubation period is completed of 14 days, still the impact of the virus is going to stay for a long time. Sometimes there is a theory that it is just staying in the midgut area for a long time. So that midgut area is slowly just wean off that virus. So it takes long time. Minimum, they are saying that if it is more than 12 months or more than 5 weeks, more than 12 weeks to 12 months, that is 1 year nearby, is called as what they are calling is long COVID. That means here the long COVID means it's mentioning about the time of illness, which is consistently, persistently affecting your life. That the time is actually mentioned as long COVID. They didn't call it as a chronic COVID because it's not chronic COVID, because it's not deteriorating. It is slowly improving, but it is taking long time. So that's why they didn't use the word internationally terminology, chronic COVID. They call it as a long COVID. So mostly it impair the quality of life and also moderate to severe functional limitation and poor health status, and dyspnea and fatigue is a very common symptoms which has been mentioned. So normally the 2 weeks is a time of an acute virus infection. 4 to 5 weeks, it's 1/5 of the people in the world are affected. And long COVID, every 1/10th of the person in this world who are affected by COVID is a long COVID case. So this shows the highest value of the physiotherapy attention to be taken care, because in every 10 patient, one patient is going to affected with long COVID. So what is the beauty of long COVID means? It is a completely unpredictable nature. You cannot predict how the disease will grow, and it is multidimensional, and it is episodic, because episodic means some patient will say that, yeah, I was all right, and suddenly I got a palpitation, and suddenly after morning 11 o'clock, I get giddiness, and after 12 o'clock, I got something like indigestion, dyspepsia. So it is an episodic and in the irregular interval, and it is severely disabled, and it has a weird symptom sometimes. I got a patient, he says that, sir, sometimes I feel that some chemical is just moving around my brain. So weird symptoms. So nobody can predict the uncertainty of the long COVID symptoms. There's some ongoing learning points. So because the COVID is keep on going on, the disease, we are still not able to understand how the disease progress and what it can come out. So we can say that it is ongoing learning points. Sometimes no correlation between the intensity of virus and severity of disease. Still yet it is not established, evidently. And there is more question in COVID and less answers are available actually. That is the beauty of the disease. And exercise is a medicine. Not every patient deserve it. This is a very, very important. This is where the Central IAP has decided under the leadership of our Honorable President, Sanjeev Jha sir, and we decided that, sir, this exercise cannot be, because we have seen during those days on second wave, the many people are giving clapping everywhere. So that video become very viral. So sir has said that, oh, this is actually going viral, which is actually a wrong perception it can create in the society. So what we should supposed to do means we have to create a national guideline. I think this is the first national guideline in IAP has done during this pandemic in the country, and it was amazing. It has been well taken by the society, and a lot of people got applauded and applause, and it has been utilized. The impact has been created very beautiful in the society. And that time he said that exercise is it's a medicine. You have to give a titrated dose. For this patient, every patient is not in long COVID is need of exercise. So you should have a selection criteria and how much you should give exercise, a threshold amount of exercise. You cannot give more exercise, or less exercise is ineffective. The more exercise can harm you. So that's why I use the word titrated value of exercise should be given. So we consider that exercise is a medicine, not to every patient. It is appropriate for some patient. We should isolate that patient and we have to give it properly. And post-COVID deconditioning is different from normal hospital, long hospital stay decondition. Suppose a patient is in ICU, he is in a long stay on the hospital, the decondition will be different compared to COVID decondition, because in COVID decondition, it is a viral impact, and viral impact with the multidimensional uncertainty of the disease. Whereas in post-normal long stay hospital deconditioning is very simple, that only you have to build the endurance, nothing else. Here, the long COVID symptoms not having any discrimination of age, background, ethnicity, gender. It is really truly global. That is a beauty. So now the COVID related symptoms, if we see during the acute COVID phase and post-COVID follow-up, the three things are very common. The fatigue is a very common. It is during the acute phase as well as the post-COVID phase. In both the phases, it is actually relevant of more than 60%. And the shortness of breath is a very important parameter, which is 40% involved even after post-COVID. And joint pain is a huge area where it is 30% it is occupying. So now during after post-pandemic, 30% of joint pain is getting confused with chikungunya. So we should be very clear to isolate that difference between the chikungunya as well as the post-COVID follow-up of joint pain. So there are a lot of other symptoms are there, like cough, loss of smell, dry eyes, mouth, nose inflammation, red eyes, loss of taste, headaches, sputum production. But all these things are secondary. The major three areas are symptoms are fatigue, shortness of breath, and joint pain, which is basically our cup of tea, which occupies the 60% of the problem. So what is the urgent reference when you are treating a patient in ICU? When you should give a reference immediately to the higher level order consultant? Severe hypoxemia or oxygen desaturation on exercise, signs of severe lung disease or cardiac or chest pain, arrhythmia, irregular heart rate, and signs of dysautonomia. That means dysautonomia means autonomic dysfunction. So these are all the symptoms. You should be very vigilant, and really I appreciate that we all together, we worked, and really national guideline for COVID on acute care patient as well as a rehab has been done by the Indian Association of Physiotherapists. And there are a lot of authors around the country has picked, and day and night they worked along with their busy schedule, and which is available in our website, IAP website, for further reading and reference, and which has been taken care by other countries also. They have taken this as because India is having a large number of population. So our guidelines is viewed as one of the best guidelines among all the countries. It has discussed very well. And even today afternoon, I'm going to talk in Dubai about our guidelines, national guidelines provided by Indian Association of Physiotherapists. So that is one more milestone for our IAP during this day of World Physiotherapy. And let us see on admission how it happens. In ICU, we got two kind of patients we get admitted. One is conscious patient, the other one is unconscious patient. So conscious patient, basically, we call it as phase 1, and they are basically, unconscious patient is phase 1, because where the patient is completely dependent on the mechanical ventilation, or even they required sometime ECMO or something like that. Whereas in phase 2, the patients who are conscious and they can cooperate, and they need a high flow of oxygen support, and they are just mid-door between the ventilator and oxygen. So this is actually a phase 2. So these are all so Indian Association of Physiotherapists, according to the guidelines, has divided the cases into 4: mild, moderate, severe, and critically ill. So mild means we have D-dimer value less than 1, whereas the HRCT score is less than 8, and home isolation is required. Only the deep breathing exercise or diaphragmatic breathing exercise, incentive spirometric, can be applied when there is a rate of respiration is less than 24. That's very important. And saturation should not be go below 94. That is the ideal key you should take for a mild case. When you are dealing with a moderate case, the drop in saturation during the activity should be vigilant, and fever, cough, breathlessness should be taken care, and D-dimer value may be more than 1, whereas the HRCT score between 9 to 19. The high flow oxygen support of benching mask should be given, and the proning is important key factor, whereas the government of India, in association with the idea of IAP, they have introduced the proning guidelines, which is again the one more useful guideline, which is very impact and effective value. I can share one experience. One of my patient, in the morning 4 o'clock, they called me that he was a scientist in ISRO. He said that he was going for a desaturation of 83 and he was having breathlessness. So morning 4 o'clock in the morning, they asked me for the bed. So we are just finding him for the bed, but until 8 o'clock, we didn't get it. So I asked him, you just do one thing, you do a proning and let us see. So after proning in 5 minutes, you don't believe that it is a miracle. He go for 93 saturation and he sustained it for up to 8 o'clock until we got a bed. So once we got the bed and he was got into ventilator and he managed after 7 days, that brain has came back as a ISRO scientist brain again back to the country. So I was just happy that the simple proning tip can help somebody to come out of his life. So really, I'm saying that we feel that the physiotherapy is a simple things makes big logics and big magics. And we can classify the patient to further severe and critically ill patients. And what are the screening you should look for the patient with a long COVID? So look for comorbidity, whether the patient is obese or diabetes or the patient is actually any other problem. And mainly hemodynamic stability you should look for, blood pressure, heart rate, and ECG. And respiratory parameters you should look for saturation, breathing pattern, respiratory rate, breathlessness is there or cough. And feasibility of mobilization, whether we can mobilize or not, we should understand. Muscle strength, range of motion, and wasting with hand dynamometer. Fatigue severity score and Bogue score can be taken for rate of perceived exertion. If the patient is in ICU, we should look for Richmond agitation scale. And 6-minute walk test and 40 minutes walk test are the ideal scales and gold standards. And you should look for skin if there is any pressure sore examination. So what are the yellow flags? Yellow flags means when you should be alert. That means, oh my God, I should take care of it. The patient should not get into trouble. So which time you should take care? Dysfunctional breathing, are fear of physical activity or exercise, fear of shortness of breath, sleeping problems, and post-traumatic stress syndrome, and negative belief and concerns about the symptoms. So these are all the, I can call it as a yellow flags. And I can give a small tip to you for rehabilitation concern. First 6 weeks, your exercise should be gradually, and activities of daily living should be increased slowly, and low intensity workout and physical activity should be Bogue score 4 out of 10. You should manage 4 out of 10. Whereas after 6 weeks, you can go for increased intensity and gradually you can build up, and you can go up to 6 out of 10 Bogue score. This is a very important key element for your basic practice. Always monitor, evaluate, and every patient is unique. Don't put them in a protocol. That's very important. And now I'm going to share few real-time experiences during COVID time. So the patients come with a problem of depression and anxiety. And I'll give you an example. We know the physiology of the disease is real. That means if you see the CT scan, we can see there is a fibrosis. The physiology is real. And impairment of organ is real. Yes, the lung is functioning is very low. And symptoms are true. Yes, he's having a fatigue, breathlessness, or sometimes Gabraman, or sometimes he is having a lot of symptoms. And emotions are uncertain because he said that sometimes I feel very good, sometimes I feel very heavy, sometimes I'm not happy, sometimes I'm so moodless. But nobody understands what is going on inside the body. That is a fact of life. It is a clueless feeling for the patient. Always the patient says that, sir, something is happening to me, but I don't know what to express. This is a commonest sentence which I just come across. So that leads to anxiety because the reality is there, but same time, the anxiety is there, but he do not know what is happening inside. So this is one of the real-time experience. The other real-time experience is some patients, they say that, sir, I'm taking BP medicine regularly, but still my BP is not same. And my heart rate is different. My palpitation is happening. Again, I went to doctor. Doctor said, yes, your dose is right. You just keep on continue the same BP medicine. So then we understand that why the BP medicine is there. Still, then we found out that one good reason, just I would like to share with all physiotherapists, that normally the COVID is virus is going and attacking your ACE receptors basically. But unfortunately, in our subcontinent, most of the BP is dealt with the medicine called ACE inhibitor. So ACE inhibitor is not working because ACE receptors are already well damaged by COVID. So that's a reason the BP is not under control and heart rate is fluctuating and the palpitation. So only answer is you should give reassurance to the patient, nothing to worry. That's a simple thing. So this is one of the real-time experiences which I learned from this COVID. And the other real-time experience I would like to share, what we practice during uncertain complaints from the patient. Patient says that I don't know what is happening, but something is happening, I'm not happy. So we listen to the patients. Yes, tell me, what are the conditions? They say sometimes some brain is moving inside, my body, heart is just moving inside. They give some awkward or weird answers. So what you should do means don't avoid them. Listen to them very carefully, with passionately and patiently with your eyes. And we acknowledge it and understand it. We support them, we make them believe that, yes, we understand your problem, we solve your problem. Give a reassurance. That's a key. So we try to, because by this kind of words only, still we are learning what is long COVID. Because long COVID, nobody says that I know everything. Because long COVID is teaching us in the form of patient, like a book, and every symptoms, when we listen to them only. If you don't listen, we have a protocol, you follow this. That doesn't work because every patient is unique in this nature, which is my real-time experience. So you have to give only real reassurance and moral boost, and you should pretend to say that, yeah, I understand your problem, even if you don't understand. That gives him more comfort and soothing effect. And the last, one more real-time problem. Some patient says that, sir, I'm doing nothing at home. You gave exercises, but I'm not going to do anything because I got exhausted. He used the word, I got exhausted. So immediately you feel that the patient is lazy. It's a commonest mindset of any physio that, oh, the patient is lazy. So you don't underestimate the value of the word exhausted because it is not maybe true. That is, he must be lazy and he must be having some other problems also. So try to be vigilant between the difference of a long COVID symptoms and new evolving disease along with him, like a cardiac failure or something. So you should be always go for a vigilant, and again you have to remonitor the structure. So that's a very important thing. So educate the difference to the patient. And other real-time experiences, mainly a sports person who got COVID, definitely he come and be unhappy with our rehab, and he always speaks a lot of things, and he is a patient more affected anxiety and depression, who is already fit or young age or young active brain, because they filled with a lot of anxiety and dejections about their functional outcome, because the reason is what they want means their expectations are too high to equate the near normal in short period, because they perceive themselves they are the sports people. But it is not mandatory you are a sports people or you are an active young man. It doesn't. The virus do not know how much the virus is going to impact you is decided by only virus, and how much you are going to come out is only going to decided by your body cells. So it cannot be decided. So there is a mismatch between the expectation and reality, will give a disappointment and dejections. So especially we have seen the people who are active young people, as well as in the sports people, have this kind of problems, which have been expectation and reality mismatch, and mind and physical function, there is a complete mismatch has happened. So what is a titrated value of program? So what you should do means do a pacing, and resting is very important. No compromise with saturation while you are doing exercise. And monitor the patient and listen to the body, what body want to say. Nowadays for listening, you have a lot of technology. Patient you can just tell them that you have a watch with the heart rate and BP, and you use that. The technology should be used, and teach how the energy can be consumed and prioritize the work.
Dr. Sandhya, our chief guest has come.
Hello.
So
Yeah, can you hear me?
2 minutes break after.
Hello.
Hello.
Yeah, can you hear me?
So yes, sir, you're audible, sir.
Yeah, can you hear me? Yeah.
2 minutes break.
Okay.
2 minutes break.
So monitoring and listening to the body is. Hello. Yeah. Teach how to prioritize the work. So basically you just inform to the patient in the morning, which is a very important work, you put it in the morning schedule, and the evening schedule you can just drop down the work where the energy is reduced. It's a law of conservation of energy. And make them to realistic goal setting, and make them into broken into pieces, and fatigue management, endurance training. So now I'm going to give some few strategy what you can manage to the COVID patient. The first and important is what I'm just saying means, ask the patient for a diary, activity diary, and this activity diary should have the very important, the activity diary should have morning what work he is doing, getting out from the bed, and he is going for a loo, or his pottery is going on, or he is going for a cooking, or he is going for shopping. Everything he put the activity of a day, and make them to 1 to 10 or 0 to 10. 0 means nothing, and 10 means a maximum he is having a discomfort, and ask him to rate it, and just create a baseline. That baseline you bring it for a week, and based on the week baseline you give a training, and that training has been rechecked with that values of the baseline which you have created with the diary. Definitely there is a huge change. The patient get motivated, and there's a wonderful experience which I had, which we did it. So it is one of the handy one. And the second one is what I want to say means, the exercise, which exercise you can just go for it. The best exercise which you can go for it is in the initial phase is eccentric exercise rather than concentric exercise, because the concentric exercise actually it consume more oxygen, whereas the eccentric exercise consume less than 80% of the oxygen where the concentric exercise is going to consume. So you can deliberately improve the endurance as well as with the low load. And the second important point is the eccentric exercise. The importance is it can build up the tissue 30% faster than concentric exercise, because it is just a control against the gravity or inertia. So the eccentric exercise is a take-home message more than the concentric exercise on the initial stages, and slowly you can just add the concentric exercise. And if the patient is having orthostatic hypotension or positional hypotension, so better is introduce the isometric exercise. That will give you a more example, more relief. So the finally a take-home message is physiotherapy play a key role in recovery of patients, and caution with the intensity of, yeah.
Sorry for interruption. Our chief guest.
Can you hear?
Sri Uma Shankar Singh. Yes, sir. Yes, sir. Sorry for interruption, sir. Our chief guest, Uma Shankar Singh, is with us. So I will take 2 minutes of yours.
Yeah.
Okay. So our chief guest of event, Sri Uma Shankar Singh, is with us, an IAS officer, Mission Director, NHM, Health and Family Welfare Department, Government of Jharkhand. So over to you, sir. Sri Uma Shankar Singh.
Thank you, Dr. Sandhya. Thank you, Dr. Aziz, Rajiv Ranjan. A very thank you for giving me such a beautiful opportunity to participate in such a relevant webinar. I think I was listening very carefully to Dr. Annamalai, and he was pointing out a very pertinent things. Let me allow to switch off my video because my internet connectivity is very weak. Am I audible, Sandhya and Ajit? मेरी आवाज आ रही है आपको?
Yes, sir. बिल्कुल अच्छे से आ रही है, sir.
Yes, sir.
आ रही है मेरी आवाज?
Yes, sir.
ओके, थैंक यू अजीत. सबसे पहले तो पूरे झारखंड टीम को, आईएपी की टीम को बहुत बहुत धन्यवाद. सॉरी अन्नामलाई सर को बीच में इंटरप्ट करना पड़ा. आई थिंक अन्नामलाई सर को हम लोग डिटेल सुनेंगे. एंड एक्सट्रीमली सॉरी, एक्चुअली मैं अभी हॉस्पिटल से ज्वाइन कर रहा हूँ. मेरे पेरेंट्स का आज कैटरेक्ट का ऑपरेशन है एंड दे आर वेरी ओल्ड एंड वो हमारे बिना कहीं जाते नहीं है. सो आई एम लिटिल बिट बिजी हियर, बट डॉक्टर अजीत एंड बाकी लोगों से मेरा जो अफेक्शन है, मेरा लगाव बहुत दिनों से है. सो मुझे लगा कि ये अपॉर्चुनिटी मुझे मिस नहीं करना चाहिए. सो बीइंग a MD NHM, what I feel, earlier to just 2 months ago, I was posted as Deputy Commissioner Dhanbad, and I experienced a lot of problem. I experienced the horrible phase of first and second COVID wave, and during second COVID wave, आप सबों को पता है कि हम लोगों ने कितने horrible situations देखे. And during that second wave of COVID, I felt there was a great need of a good respiratory therapist, physiotherapist in government sector. Truly speaking, जो मैं अन्नामलाई जी को सुन रहा था, फिजियोथेरेपी अपने आप में एक बहुत बड़ा साइंस है, बट somehow हमें लगता है कि नॉर्मल मेडिकल साइंस की तरह अभी भी लोगों में इसको लेकर बहुत ज्यादा अवेयरनेस नहीं है. बहुत ज्यादा लोग अभी इस चीज को अडॉप्ट नहीं कर पा रहे हैं, स्पेशली इन गवर्नमेंट फील्ड. ऑब्वियसली प्राइवेट सेक्टर्स में लोग इसके बारे में अवेयर हैं, प्राइवेट हॉस्पिटल्स में काफी अच्छे एक्सपर्ट्स हैं. इन गवर्नमेंट फील्ड, इन गवर्नमेंट हॉस्पिटल्स, समहाउ आई फील कि अभी भी बहुत ज्यादा कुछ करने की जरूरत है. जैसे हमारे 24 डिस्ट्रिक्ट्स झारखंड में हैं. 24 डिस्ट्रिक्ट्स में अगर हम देखें तो हमारे जो फिजियोथेरेपिस्ट हैं बहुत गिने चुने हैं. हार्डली आई थिंक अप्रोक्स 60 to 80 के आसपास होंगे हमारे गवर्नमेंट मशीनरी में. मुझे ऐसा लगता है कि बाकी चीजों पे गवर्नमेंट ऑफ इंडिया और झारखंड सरकार को ध्यान देने के साथ साथ फिजियोथेरेपी के डिफरेंट डायमेंशंस को जोड़ना चाहिए. इसके फ्यूचर एक्सपेंशन को कैसे और अपग्रेड किया जाए उसको देखना चाहिए. हमारे फिजियोथेरेपिस्ट के फ्यूचर ट्रेनिंग, उनकी कैपेसिटी बिल्डिंग, उसके ऊपर ध्यान देना चाहिए. कैसे रूरल पॉपुलेशन में, एंड आई थिंक इस बात से जितने भी पैनलिस्ट हैं वो एग्री करेंगे कि आज भी रूरल पॉपुलेशन हमारा जो है, रूरल पॉपुलेशन, ट्राइबल पॉपुलेशन, वो या तो फैक्ट्स के चक्कर में आ जाता है, उनको बहुत कुछ पता नहीं है फिजियोथेरेपी के बारे में. जबकि मेरा अपना मानना है कि बहुत सारी चीजें फिजियोथेरेपी के माध्यम से ठीक हो जाती हैं. मैं खुद क्रॉनिक लो बैक पेन से सफर कर रहा हूं. मैंने रांची के अच्छे फिजियोथेरेपिस्ट से अपनी इलाज कराई एंड काफी ट्रीटमेंट में इम्प्रूवमेंट हुआ. बट मुझे ऐसा लगता है कि अब ये धीरे धीरे आम लोगों तक इसको पहुंचाने की जरूरत है, आम लोगों में अवेयर करने की जरूरत है. एंड गवर्नमेंट पॉइंट ऑफ व्यू से मुझे लगता है कि हम लोगों को भी एक स्ट्रांग पॉलिसी लेकर आनी पड़ेगी कि कैसे इसको आम जनमानस तक अवेयर करा सकें। खासतौर से हमारे एक अभी रिसेंटली कॉन्सेप्ट आया, मैं चाहूंगा कि इस फोरम पे मैं जरूर उस बात को रखूं। गवर्नमेंट ऑफ इंडिया एंड 15th फाइनेंस कमीशन का मैंडेट है कि बाय 2020 वी हैव टू एस्टैब्लिश एटलीस्ट 1,22,000 हेल्थ एंड वेलनेस सेंटर। और ये हेल्थ एंड वेलनेस सेंटर सबसे निचले पायदान पे जो हमारे पंचायत होते हैं, जो पूरे विलेज लेवल पे हमारे हेल्थ वेलनेस सेंटर को स्टैब्लिश करने की बात है। अगर इस हेल्थ एंड वेलनेस सेंटर में आयुष के जो चिकित्सा है उसके साथ साथ हम फिजियोथेरेपी को ऐड कर सकें, योग को ऐड कर सकें, ये हमारे लिए काफी बेटर होगा। इस फोरम पे मैं अपील करूंगा हमारे आईपी से कि इस तरह के इवेंट को ब्लॉक तक लेके जाने की जरूरत है, डिस्ट्रिक्ट तक लेके जाने की जरूरत है। हमारे जो ब्लॉक के ऑफिसर्स हैं, मेडिकल ऑफिसर्स हैं, उनको अवेयर करने की जरूरत है। रांची में इस तरह के इवेंट आई थिंक साल में एक बार होते हैं, बट आई होप कि हम लोग रेगुलर हर 3 महीने पे 6 महीने पे अगर इस तरह के इवेंट करें तो हमारे काफी लोग इससे लाभान्वित हो सकते हैं। डॉक्टर अन्नामलाई एंड बाकी जो स्कॉलर आज जुड़े हुए हैं, ऐसे लोगों को हम बीच बीच में इनवाइट करें, उनका स्पेशल सेशन रखें अपने फिजियोथेरेपिस्ट के लिए। फिजियोथेरेपिस्ट को रिसेंट जो अपडेटेड नॉलेज है उनसे हम अपडेट करें, तो मुझे लगता है आने वाले समय में ये काफी फायदेमंद होगा। मुझे याद है कि सेकेंड वेव के समय जब हम लोग काफी ज्यादा स्ट्रगल कर रहे थे पेशेंट के रिकवरी को लेकर, तो उसमें प्रोलॉन्ग स्लीपिंग पोजीशन की बात आ रही थी, उसके बाद रेस्पिरेटरी थेरेपिस्ट की बात आ रही थी। और आप ये जान के काफी सरप्राइज होंगे कि किसी भी डिस्ट्रिक्ट्स में गवर्नमेंट मशीनरी में हमारे पास रेस्पिरेटरी थेरेपिस्ट के डॉक्टर नहीं है। आप रेस्पिरेटरी थेरेपिस्ट की बात छोड़िए, अगर स्पाइन सर्जरी से रिकवर होने की बात हो या कोई अन्य बीमारी से रिकवर होने की बात हो, तो उसके लिए भी आज हमें प्राइवेट सेक्टर की ओर मूव करना पड़ता है। तो मुझे लगता है कि आईपी के सभी फिजियोथेरेपिस्ट, सभी जो पैनलिस्ट हैं, वो जरूर इस बात से एग्री करेंगे कि हम अपने मेडिकल साइंस को कैसे धीरे धीरे आम लोगों के लिए सुलभ बनाएं, एक्सेसिबल बनाएं, ये बहुत इंपॉर्टेंट है। और बीइंग एमडी एनएचएम मैं ये जरूर कमिट करना चाहूंगा, अजीत हैं और अजीत के साथ पूरी टीम यहाँ पर जुड़ी हुई है। गवर्नमेंट की ओर से जो भी आपको हेल्प होगा, एनएचएम की ओर से जो भी हेल्प होगा, आपके पास कोई आइडियाज हैं रोल आउट करने के लिए डिस्ट्रिक्ट लेवल तक, ब्लॉक लेवल तक, पंचायत लेवल तक, लॉजिस्टिक सपोर्ट चाहिए, पॉलिसी सपोर्ट चाहिए, एडमिनिस्ट्रेटिव सपोर्ट चाहिए, वो सारा सपोर्ट हम लोग देने को तैयार हैं। लेट्स कम अप विथ डिटेल्ड ब्लूप्रिंट कि हम लोग कैसे आम लोगों तक इसका फायदा पहुंचाएं। और मैं जरूर गवर्नमेंट ऑफ इंडिया की भी जो फोकसेस है उसके बारे में बताना चाहूंगा कि गवर्नमेंट ऑफ इंडिया भी इस बारे में काफी कंसर्न है। एटलीस्ट हम लोग हेल्थ वेलनेस सेंटर हमारे पूरे झारखंड में 3050 हेल्थ एंड वेलनेस सेंटर बाय 2022 तक हमें स्टैब्लिश करने हैं। इन सभी सेंटर पे अगर हम फिजियोथेरेपी के मेडिकल साइंसेस को बहाल कर सकें, उनको इंट्रोड्यूस कर सकें, तो अपने आप में बहुत बड़ी बात हमारे लिए होगी। सो थैंक यू आईएपी, थैंक यू अजीत, संध्या, राजीव, अन्नामलाई जी एंड बाकी जितने भी डिग्निटरीज जुड़े हुए हैं मुझे बोलने का मौका देने के लिए। एंड सॉरी मैं कंटिन्यूअस नहीं जुड़ पाऊंगा, बट मैं आप सबों से टच में रहूंगा। और मैं चाहूंगा कि जितने भी पैनलिस्ट हैं, जितने भी स्कॉलर जुड़े हुए हैं, उनका नंबर, उनका मेल आईडी प्लीज शेयर कर दीजिए। और मेरे लायक कोई भी गवर्नमेंट सेक्टर में हेल्प चाहिए होगा तो आप बताइए, हम लोग इसको टॉप प्रायोरिटी में आगे लेके जाएंगे। ओवर टू यू अजीत एंड संध्या।
थैंक यू वेरी मच सर, थैंक यू फॉर योर मोटिवेशनल वर्ड्स। इतने क्रूशियल टाइम में भी आपके पेरेंट्स का ऑपरेशन है और आप यहाँ पे आए हमसे जुड़ने के लिए बहुत बहुत धन्यवाद। नाउ हम अपने लेक्चर को शैल वी कंटिन्यू सर? डॉक्टर अन्नामलाई सर।
Yeah, thank you so much. And Umashankar sir, thank you so much. During this critical time, you have given a beautiful time for us, and really it shows that love and commitment towards the physiotherapy. and being a physiotherapist, we are loving physiotherapy, and you are not being the physiotherapist, you are giving this crucial commitment. So really, we appreciate your time and your words, kind words. And definitely our Ajit sir is there in Jharkhand, and he's a master key for all the growth over there. So I think definitely we will make use of it, and we will go for a further growth of our field, sir. Really thanks for your wonderful time. And
thank you Annamalai ji.
yeah.
Thank you Ajit. Ajit is very kind to me, and Ajit हमेशा मदद करते हैं. And Ajit is very Ajit, Rajiv Ranjan, they are very active.
So thank you so much.
एपिसोड आईपी का बहुत प्रोग्रेस करे. इसी शुभकामनाओं के साथ मैं आपको सभी थैंक यू अजीत.
Thank you, sir.
Thank you, sir.
And just okay, can I continue, sir?
Continue, sir.
Yeah, can I continue?
Yeah, yes, sir.
Yes, sir, sure.
Yeah. So I was at the verge of finishing only, but anyway, we got a very good sandesh or subiksha from the person who is just a man who is having a lot of love and affection to our field. So I think we can wait. This day is special day, not for us. This is a special day for the patients and the lovers who are loving our field. So I think it's worth for giving a good time to them. And finally, I'll come to the take-home messages. Physiotherapy play a key role in recovery of patients. Nobody can deny it. But one thing is, you should be very vigilant that caution with the intensity of activity and exercise is needed. That means again and again, I'm using the word, a titrated value of exercise will give a wonderful output. Gradually improve the activities of daily living is a first focus. And after 6 weeks, the intensity can be improved. It's a very important take-home message. And isometric exercise can be used for the patient who is having orthostatic problems. And you can use the initial phase, the eccentric exercise, which is always better than a concentric exercise on the initial days. And monitor, measure, and evaluate. That's very important. Still, I can say that work in progress, because nobody can be read or nobody can understand, nobody can pen a book or a journal in case of long COVID-19, because it is an ongoing process. Still, we are awaiting for the problems and solution for the future waves. And no new evidences are coming every day, and clinical evidences are increasing, and physiotherapy recommendation will be reviewed soon once a third wave comes, or even if it is not come, because we are learning curve, whole world is on the learning curve. And a multidisciplinary clinical practice approach is required, and guidelines has to be developed in our country also, the multidisciplinary group. And we are awaiting for the third wave, and we pray for Almighty that it should not affect us much. And the only simple word before thank you is know what you do. This is very important in COVID. Know what you do and do what you know only. Don't do beyond that, because that's why it's a critical value of the exercises. If you do more exercise, it can affect you. If you do a less exercise, it won't be having any impact. So threshold of exercise is a key for long COVID rehabilitation. With that note, I'm really thankful to the entire Jharkhand IAP and the entire Jharkhand IAP. I wish you the great, happy World Physiotherapy Day, and hope this 2021 is going to be a new era for us, and hope we'll grow further. And especially thanks for Ajit sir, because I was actually confusing myself for time and date, and really patiently waited, and he was just handling me. And thank you so much, sir. And thanks for the entire team. And my president has already spoken beautifully. So again, it's a wonderful wishes once again. Thank you so much.
Thank you so much, sir. Wonderful session, very informative, sir. हम आगे भी आपके लेक्चर्स को सुनने को चाहेंगे, सर, कभी अगले सेशंस में. So
no, actually, I'm on a.
Yes, sir. Yes.
I'll stay for 5 minutes, then I'll be just going for the next.
Okay, sure. And here is the second lecture on same topic, rehabilitation and long COVID by Dr. Sunit Wagre, Assistant Professor, NIMS, Physiotherapy College, Hyderabad. Over to you, sir. Dr. Sunit Wagre.
Good afternoon. Good morning, everybody. Can you hear me?
Sir, you are audible, sir, but video is. Video is not coming, sir. You are audible.
Can you hear me?
We can hear you,
Hello?
sir, but your video is not coming.
Hello.
Hello. You are audible, sir.
Shall I share my slides? Is it okay for you?
Yes, sir. Sure. Yes, sir. Now you are visible.
एक मीटिंग के लिए
Yes,
इतना
sure.
काम करना पड़ेगा डेटा डेटा चाहिए इसलिए टेंशन हो
Just a
जाता
second,
है
sir. I can't hear you.
वो फोन के पीछे पड़ा रहता है आगे अभी समझ
कुछ टेक्निकल इशू है, सर कनेक्ट नहीं हो पा रहे.
Ma'am, can you hear me now?
Yes, sir. You're audible, sir.
Okay.
But your
Just-
video is not coming, sir.
Yeah, one second, ma'am. There is some problem with the.
Yes. Hello. Your screen sharing is visible now, sir. Hello.
Can you hear me now?
Yes, sir. You're audible now.
Ma'am, can you hear me?
You're audible now, sir. It's sir थोड़ा रुक रहा है audio.
Hello, ma'am. One second. Can you hear me?
It's very disturbed, sir. Your audio is very disturbed.
I'm starting my session.
Yes, and now you're audible. Yes.
Uh, this is actually an evolving disorder.
Recording in progress.
COVID-19 is evolving. It is evolving. We still don't know what exactly is going to happen next. But what we know, we can speak now. It's a normal human coronavirus, causes 5 to 10% of the common cold. Common cold, upper respiratory tract infections with outbreaks of 13% of COVID-19, 30% of common cold. There are basically four variants in that: alpha coronavirus and beta coronavirus. Beta has 2 and alpha has 2. This is known to us. These four predominantly attach to the upper airways, as in the normal seasonal flu. But seasonality is still unpredictable. We do not know what exactly is happening, going to happen. Seasonal flus, everybody knows that change of season can cause seasonal flus, but this is a little bit typical. It is coming in all the seasons. Mainly it is upper respiratory tract symptoms, croppy or dry cough, rarely pneumonia, but now pneumonia has also become very common. mild diarrhea in infants. This is known to us. COVID, it is a respiratory disease which impacts the health of an individual as a whole. World Health Organization declared it as a pandemic on 11th February. First case was reported in Wuhan in 2020. Vaccine is the only way to prevent it, but some people who are vaccinated also are having symptoms, though the symptoms are very mild and they do not go for hospitalization. Majority of the patient presented with fever, sore throat, cough, shortness of breath, and chest pain. The acute illness is mild in majority of the patients. Around 20% of those infected need hospitalization and around 5% require critical care with non-invasive or mechanical ventilation. Now, we divide the entire COVID patients into 3 groups. One is those who require severe manifestations such as ARDS, and requiring ICU admissions. Those who were not admitted during acute illness but later presented with symptoms and signs of end organ damage such as cardiac, respiratory diseases. Then the third part is they presented with symptoms and prolonged symptoms without evidence of any end organ damage. There are 2 misconceptions and we have to come with facts also. The misconception is all patients with COVID-19 recover in 2 weeks. This is not always the case. Long-term consequences of COVID-19 infections are still not very understood. As Annamalai sir has highlighted that it is still an ongoing process. We really don't know what is going to happen next, whether the third wave will give you some different things. In addition, prolonged recovery of symptoms have been described even in patients who had milder symptoms and did not require any hospitalization. This manifestation may be termed as post-COVID syndrome or long COVID. Now, long COVID, it is relatively a new phenomena, still under research, not well organized or not well recognized. Now, it could be because of possibly a collection of 4 symptoms. One is post-viral fatigue, fluctuating multi-system failures. Then you have lasting organ damages and post-infective care. The fluctuating multi-system failures has to be acknowledged as a new symptom or that can cause long COVID. Now, the first point is it's interesting to note that post-COVID-19 syndrome is more common in women than in men. Probably this can be the first disorder which is more common in women than in men. A common theme is that symptoms arise in one physiological system, then abate only to find symptoms that arise in a different system. It's like this. For kids, it arises in the form of diarrhea, that is gastrointestinal tract. Then it stops over there and unabates in the respiratory system. Whereas in adults, it starts in the upper respiratory tract, it stops over there, then it starts in some other system. So this is very typical of COVID-19. This was recognized only after the first wave got over in India and Europe. Now there are some significant psychological and social impacts that will have long-term consequences in individuals and for society if not well managed. Now the whole point of psychological impact is that the patient has been quarantined for almost 15 days from the time they report the symptoms till they get a negative report. So that plays one of the most, that has a more psychological impact on the patient rather than the treatment itself. Sorry. What is long COVID? The presentation and management of long COVID, basically it can be broken down into 3 things. First is acute COVID-19, signs and symptoms of COVID-19 for up to 4 weeks. Second one is ongoing symptomatic COVID-19. And the third one is post-COVID-19 syndrome. Now, ongoing symptomatic COVID-19, signs and symptoms of COVID-19 from 4 to 12 weeks. Then post-COVID syndrome is one thing. You have the signs and symptoms developed during or after the infection, consistent with COVID-19, continue for more than 10 weeks and are not explained by any other alternative diagnosis. This is very, very typical of COVID. In the initial phases, we thought it is more of an upper respiratory disorder. It goes into the lungs and it forms clots and leads to lung fibrosis, which is resolving on its own. But there are patients who have reported the fibrosis of the lung is lasting for long duration of time. Many people have reported Many people have reported that the fibrosis is there. The fibrosis is there for more than 6 months or 8 months. Long COVID has commonly used to describe signs and symptoms that continue or develop after acute COVID-19. Includes both ongoing symptomatic COVID-19 and post-COVID syndromes. We need to recognize at the early phase whether the patient is symptomatic or asymptomatic. We need to recognize that at the early stage. Initially, if we do an endurance test or a fatigue test in the initial stage, after every 2 weeks, if we keep on going, we'll really understand where exactly the patient is going. So the same thing should be continued for minimum 3 weeks after the quarantine period has ended. Now there are thousands of patients who require long COVID who require research, rehabilitation, and recognition. That is still not there. Now there are people who have reported 85 days of chest pain, dizziness, high temperatures. There are people who have reported long COVID. There are people who have reported long COVID like chest pain and tachycardia. There are people who have reported fatigue, muscles ache, breathing difficulties, rashes, itching, all other things. Now there are people who have reported chest pain also with high blood pressures and fluctuating blood pressures. People who have reported brain fogging. People who have reported brain fogging also.
Recording in progress.
So these things have to be recognized. There are certain things, acute post-COVID syndrome. Now you can see in this chart, left side is the symptoms, acute COVID-19 phase, post-COVID-19 phase, follow. You can see the symptom that is very common. Symptom that is very common is fatigue. Symptom that is very common is fatigue. Second is dyspnea, joint pain, chest pain, cough, anosmia. Then you have other things that are related to that: red eyes, dyspepsia, dysgeusia, sputum production, lack of appetite, sore throat, vertigo, and other things. Now these are certain common symptoms, but the major symptom that is coming up is dyspnea and fatigue, and at times joint pains and chest tightness and pain. These are the commonest symptoms. Cough was present in the acute phase, but as the post-COVID syndrome, you can see the cough has deteriorated. Now, what these long-term COVID symptoms lead to, the first 5, shortness of breath, fatigue, joint pains, and everything, they lead to a reduced mobility. Whereas the other symptoms, that is loss of smell, Zika syndromes, running nose, red eyes, loss of taste, headache, they lead to poor nutrition and sudden weight loss, which cannot be explained by any other alternative diagnosis. So these are certain common symptoms which we can see over here, and what it can cause is over here. Now, the most common long COVID symptoms are multiple, varied, fluctuating over a period of time. The most common is with the respiratory system. Then you have the musculoskeletal system, then neurological systems, cardiovascular, GI, general fatigue, psychiatry, and sociological disorders. Now you can see again over here, general and post-exertional fatigue amounts to 93% of the patients reported this. 81% patient reported persistent SOB. Now, this statistics is not from Indian research. Indian papers have not been published yet, but these are all Western research, especially from Europe, countries like Italy, Spain, and some parts of US. Persistent cough is still there. Headache is one of the major issues that has to muscle fatigue and pain, muscle pain. These are one of the issues over there. And you can see sleep disorders and mood changes. This is one of the most important psychological disorders or important disorders which, as a physiotherapist, we have to take care apart from post-exertional fatigue, shortness of breath, headaches, pain, and muscle fatigues. Who gets long COVID? Now, this is a question that keeps on lingering in everybody's mind. All healthcare professionals think that, okay, 15 days are over, you're fine, you can go. No, it is not like that. There are certain criteria given over there. There are certain criteria based on research which has come up, like increased age. Increased age. If the age is more, people who are geriatric, they get it. But that does not mean that people below that age do not get it. They are still getting it. The percentage is less. 2.5 to 15% of the people are still symptomatic with the same symptoms they are living. Then, as I told before, female gender is one of the main. Female gender has been found to be one of the more factors which are where we can see long COVID. then you have obese patients, then you have people with asthma. This is found to be very relevant. People with asthma definitely end up with long COVID. Multiple symptoms at the time of presentation. When you present, if you present with multiple symptoms like cough, fever, chest pain, gastrointestinal issues, all the things will lead to you can say that, okay, this person is going to present with long COVID. So you have to start at that time only. Patients may not have a positive COVID-19 test, but presented with COVID with symptoms of COVID-19 later on, long COVID later on. This is another important thing. People had symptoms, the same symptoms, cough, cold, and other things, but they did not have a positive RT-PCR report. But later they had these long COVID symptoms. So this is one thing which is really tricky. We still do not know the cause for it. There are some patients, the amount is less, the percentage is very less, but still it is present. Now, new vulnerable people who can still fit into this category are active elderly. After the second wave, this has been found. People elderly who are active also will get this problem. Young and fit COVID-19 patients will end up in definitely in long COVID. Critical care patients who required ICU admissions, definitely they are going to have this issue. COVID-19 survivors, long-term COVID patients, they come in this categories. Most important part is healthcare professionals and others suffering with facial damage due to wearing of PPE. They can also come into this category. And those carrying different roles in healthcare, caregivers can also fall into this category. Now they are still termed as long COVID patients. They might not present with the symptoms, but they'll have issues related to long COVID. They can present with signs and symptoms of long COVID in the form of fatigue, sleep disorders, muscle pains, other things. Now, when you're treating a long COVID patient, there are certain things you should keep in mind that these things can happen when you're treating them. Cough will be present in 82% of the people. Fatigue will definitely be there. Shortness of breath and myalgia. These are the things that will be present. When these things are present, be rest assured that there is decreased strength and endurance. And due to that, you have a reduced mobility. Now, there are certain evolving features which we are finding in treatment of long COVID patients. They are hypoxemia, tachycardia, hypotension, and hypertension. Now, this tachycardia part has to be taken into account whenever you are going for planning for long COVID patients. Exercise program for long COVID patients. Now, we have a 4-tiered approach which we can take when we are treating long COVID, or in general, if you are taking COVID patient also. A generalized management protocol. Suppose a patient comes with you, you do not find any major symptoms of long COVID, just prepare a generalized program for his, depending on his activities or daily living, or depending on what kind of work environment he is going to go, prepare a generalized management program and pass it on to him. Then you have management of specific symptoms. Like some patients present with vertigo, some patients present with only shortness of breath, some patients present only with pains. So you have to manage those specific things. Now there are some cases, a few cases, which have presented with only right knee pains post-COVID. Their left lung was damaged and they presented with right knee pain. So we had these kind of patients, but still the connection between the two is still not known. So we had to be specific with the knee pains. Third point is management of specific symptoms with specialists. There are certain things as a physio, you cannot manage it on your own. Always take a help of a specialist. Go ahead and plan a treatment accordingly. The fourth tier is assessment and management of long COVID who are having all the symptoms together. Multiple systems. So those patients come under a different category. These are the 4-tiered approach which we should follow when we are treating long COVID patients. Now, this is one functional scale which has been derived from Oxford. They say that if you grade once you assess, once you go for the subjective, go for a functional scale of a patient before putting him onto a rehab program or putting him onto a program which is going to help him back to his normal. We should know where actually he stands. So again, you can see in this is mainly connected with his activity to the daily living or self-care. You can see, can he live alone without any assistance from any other person? If no, then he falls under a severe limitation category. Then if yes, you have to further start doing what are the duties he is doing at home. You have to see, and whether he is able to perform them by himself or not. If he says, or at work, which you are no longer able to perform, if he says no, then do you suffer from other pains and symptoms and depression? Then you say no, then he doesn't have any issues. He can become a normal he can start with his normal activities. Again, graded exercise program should be given for this patient slowly. Then the second part, if he says yes, then he forms under the moderate functional limitations. Then here, if he still has symptoms of depression and anxiety, you have to further evaluate and see whether he forms in grade 1 or grade 2. This is one aspect. The second aspect of the PCFS scale is, again, what type of limitations does he have? Depending on that, if he doesn't have, it is 0. And if he's suffering from severe limitations, that is ADL is affected, day-to-day activity is affected, then he forms under the category of 4. So this is one simple assessment tool. As a physiotherapist, you can take out a paper, you can write it down. PCFS scale, A is this, B is this. There ends the matter. You can understand where he is going. This is one aspect. The second aspect is post-COVID Oxford screening. Now here, what they have done is they have divided the category into post-COVID, 14 days or 15 days of quarantine, or patient who has been admitted, discharged 15 days later. What type of symptoms they are observing, what type of symptoms they are having, and for how long in the next 15 days. They have observed those things and they are asked the patient to come up with the answers. It's like fatigue, pain in the same symptoms, fatigue, pain in the joints, mobility issues. You can see the right hand side, it is different from pre-COVID. That means to say he is not having fatigue, but he is not normal as he used to be before COVID. So this plays a major role over here. So these are the things which you have to. Now this gives a broad overview of what exactly we have to do, where exactly as a physio we have to concentrate and move where. This becomes a very good clinical tool for us when we are treating patients. Now the last part in this is very important for us. A change to your voice, whether his voice is changed, toning is changed, what type of difficulty is he finding at the end of the day. This is one aspect. And the second aspect is communication. Whether when he is conversing, is it making any sense when he is conversing? That is part. Second part, and whether he is having difficulty in reading. There are issues related to reading also. They are not able to, if they are reading well, they are not able to comprehend what they are reading. And then when they are conversing with their people at home also, they do not make sense in what they are conversing. Last part is very important, is sleep disturbances with vivid dreams or nightmares. One more point that is yet to be included is they are having sweating, profuse sweating in the night. This is related to the autonomic nervous system. Why it is happening, it is still not known. There are 2 to 5% of patients, 2 to 5% of patients who reported that they are having autonomic dysfunction in the form of sweating in the night, profuse sweating in the night. Now, then you have a fatigue scale. This is a very easy scale, as Annamalai sir has already defined it before. It's just like your pain scale, where you have 0 is no pain and worst possible fatigue. 0 is no pain and 10 is maximum pain, where you're not able to manage things. In this fatigue scale, it is so simple. It's a fatigue numerical scale. 0 is no fatigue, and the patient is feeling very energetic. He can do whatever he wants to do, where 10 is possibility, worst possible fatigue. This is basic assessment. Then you come to the strength aspect. The strength is decreased due to 3 things. One is you have loss of muscle mass due to inflammatory response. The second is lack of oxygen to muscle, lack of oxygen to the muscle tissue during his acute infection. Then the third aspect is muscle damage due to inactivity. This plays a major role in people who are asymptomatic. So we do not ask them to do exercise in those 14-15 days. Once that activity is decreased, definitely when he becomes a little bit active, smallest thing can cause damage to the muscle. When you're testing muscle, when you're testing the strength of the muscle, keep in mind the low oxygen level at rest and an activity. Always keep a pulse oximeter in hand to know what exactly is happening with the patient, how much amount of SpO2 is measured over there. If there is a drop, then stop immediately, start with breathing retraining, then again come back to the strength training exercise. Then you have to measure a gross strength by 30 seconds sit to stand strength, and you have a grip strength. Now these are the mean averages that are for the grip strength. You can take it. This gives a very vague view of whether the patient is able to manage things or not, whether the patient's strength is good or not. Now, when we go for functional capacity, everybody knows that 6-minute walk distance test has been used most common in all the COVID-19 patients. it was mandatory for post-discharge from the hospital to know whether the patient is able to walk for 6 minutes or not, and whether there is any drop in the saturation post 6-minute walk test, or if there is a drop, how much time he is taking to recover with that. So those things have been taken into account when the patient is getting discharged. This was made mandatory for all the patients who were getting discharged from the hospital. If the patient is not able to walk, then what? The question comes. Then you come up with 1 minute sit-in standard. This is found to be reliable and valid. But again, it has got certain limitations to it, that there is a standardized number of sit-ins, number of times the patient can sit and stand for age, related to age, age and gender. So you have to follow that regime. But after 1 minute, our main concern will be the saturation point. So pulse oximeter, whether the patient is desaturating or not. After 1 minute, if he is desaturating, how much is it desaturated? Note it down. Then start with your exercise regime and come back after 2 weeks to see whether he's still desaturating or not. As everybody knows, the functional mobility is connected to strength, endurance, which are both interconnected again. When we want to improve this functional mobility of the patient, we have to keep in mind 5 aspects of movement when you are doing rehabilitation. The 5 aspects are deep breathing, addressing vestibular dysfunction, because vestibular dysfunction has been found to be the most common symptom in all the COVID-19 patients, whether the patient is asymptomatic, taking rest at home, home quarantine, whether the patient has been admitted in the hospital for giving some antiviral drugs or any other thing, whether the patient was admitted in ICU, acute, chronic, but vestibular dysfunctions were the most common symptoms over there in the form of giddiness. Now, deep breathing, addressing vestibular function, re-engaging large group of muscles, building strength and improving endurance. Now, breathing techniques, individualized program to control over the given individualized program to control over their breathing. The most effective way is to be slower and more intentional. This is one way of doing it. Then in breathing techniques, you have 5 aspects. One is controlled breathing, inhale, exhale. Then you have breathing control while walking. That is another aspect where you have to ask the patient whether when he is walking, 1 step breathe in, 2 steps breathe out. This is the simplest way of starting breathing control. Then you have something called as pursed lip breathing. People who are not able to walk start with pursed lip breathing. Now there is a new thing that has come up in the form of triangular breathing, square breathing, and rectangular breathing. Now these are different types of breathing which are already there. As a physiotherapist, we have been using, but the figures have come up to look it more fancier and for the patient to understand. Here you can see the patient inhales for a particular period of time and exhales for the same period of time and pauses for the same period of time. Here you can see the patient inhales, holds the breath and exhales, and again holds it for a particular period of time. Here you can see the patient inhales and breathes out for a longer duration of time and again inhales. This is one aspect you should remember. Now, thoracic expansion exercise, why this has been given importance is because COVID-19 has been found to be a more of a restrictive pattern, whereby the compliance of the lung and the chest wall has been increased. So the patient will not be able to inspire more. What we can do, we cannot change anything with the compliance of the lungs, but we can do something with the compliance of the chest wall. What we are actually doing when we are using thoracic expansion exercise, we are making it easy for the patients so that the chest tightness is decreased and there is less amount of pressure, less amount of resistance giving to the expansion of the lungs. That's the only reason that the thoracic expansion exercises have been incorporated into the treatment regime. Then you have sustained maximal inspirations in the form of incentive spirometry. This can also be used. There are 2 ways of doing it. One is a volume control and one is a flow control. Flow and volume control, 2 different aspects. Start with, in this case, we use only flow control rather than using volume control and incentive spirometry. Now, there are some people who reported that they are having sputum production along with cough. So for those people, ACBT has been found to be very effective in these kind of patients. So ACBT is one technique which has been very effective in COVID-19, post-COVID, long COVID patients who had a problem with their cough. So it was advised to learn this technique and ask the patient also to learn it so that his bronchial hygiene is maintained. Now, vestibular disturbances mainly controls the balance and sensory input of the body and is in turn on by moving over head, our head and eyes. This has to be assessed. You can just blindly start. This has to be assessed because people at different levels present different kinds of symptoms. But the basic exercises will remain the same for people who are having vestibular discomfort. One is gaze exercises. The second is head nods, rotations, rocking while sitting and standing, and normal everyday movement like rolling in the bed, standing up and sitting down. Now, these things have to be addressed, that had to be taught to the patient depending on his condition. You cannot teach all the things at the same time. This will progress once the patient comes to a stage where he's able to sit and stand on his own without any vestibular disturbances. But these things have to be kept in mind. Now, strength and endurance is significantly decreased. What we have to do is you have to design an individualized program that incorporates large group of muscles and arms. Then the second part is marching in one place and walking, reaching and bending can work to strengthen the large group of muscles, or you just activate those muscles which have been deconditioned or condition those muscles which have been deconditioned. The third part is once the patient reaches to this level, then you start with biceps curls, with weights, shoulder movements, calisthenics, activities that raise the heart rate, can improve endurance, reduce fatigue with the goal of resuming their previous routine activities. Now, this has to be very much individualized. Now, everybody knows the principles, that is the FIT principle: frequency, intensity, time, and type. But exercises start with lower extremity because they comprise the largest group of muscles along with ventilatory muscle training. Then go ahead with the arm exercises. Then types of exercise, you have endurance or aerobic training. Then you have strength or resistance training. When do we start the exercise? That is the first question that comes to the mind of as a physio. People say that once the patient is discharged or 14 days of quarantine period is ended, you can start immediately. But at times we have seen that if you delay the starting of exercises for another week, it's not going to cause any harm. Delay after check the functional capacity of the patient on the day of on the last day of quarantine. Start with basic muscle loading exercise or conditioning exercises. After 2 weeks of starting that, again measure the same thing. If the patient is improving and there is no drop in the saturation, start improving from that time. But measurement of saturation is not the only criteria. You need to measure the heart rate also. People with these symptoms, they show a very good saturation level, but they're present with tachycardia. For those patients, we need a different type of regime. This is one aspect which has to be understood as a physio when we are treating these kind of patients. Now, strength training, as already Kannamalai sir has told, concentric is much better than eccentric. When you want to initiate eccentric exercises, initiate with low loads to avoid muscle damage and inflammation. Now, the question again comes, when do we start with eccentric exercises? Concentric can be started easily at an early phase, but eccentric exercises like loading of the exercises, when do we start with? 2 weeks of concentric training and conditioning the body, you can start with the eccentric training or overloading the system. How do we do it? That is two times a week or less than that will be the starting phase. After every 2 weeks, start increasing. Now, what do we increase? That's again, how do we start increasing? Begin with low weights, resistance, and higher repetitions. On individual, start with individual basis, higher weights, fewer repetitions may be indicated to promote strength development. What is light intensity? Light intensity is 40 to 50% of the one repetition maximum, 10 to 15 repetitions per set. Moderate intensity is 60 to 70%, one repetition maximum. Now, this intensity it's a gross skeletal network that has been given. You can reduce or increase depending on the patient's capacity. Okay. Now, progression can be made by increasing the weight, repetition, increasing the number of sets, increasing the number of sets per session, reducing the rest period between the time. If the patient is able to perform 1 or 2 repetitions over a discrete period of time for 2 consecutive sessions, you can increase or decrease the number of sets, or you can increase the rest period between 2 sets. Well, that depends on the patient's capacity. But as told before also, rest is always a must between 2 types of exercise, or if you're changing from one exercise to the other exercise, rest is always necessary. How do we calculate the rest? There is no hard and fast rule over there, but 50% of the time taken to perform the rest perform the exercises should be taken as rest period between 2 exercise sessions, 2 exercise sets. Now, endurance training, again, walking, stair climbing, bicycle ergometer. No treadmill is advised as such now, but there is no documentary evidence to show that treadmill has been very effectively used or not used. That's the reason we have kept a treadmill as no for as of now, because that will increase the gravitational forces onto the knee and body parts. That will cause major other issues. Balance issues are already existing in COVID patients. That's the reason we have stopped treadmill as of now. Now, what do we do with endurance? How do we do? This is one regime which is to be followed. As a physio, everybody knows it has to be followed. But unfortunately, when it comes to the patient care, we try to neglect it, or the patient tries to forget it. So make it a point that you are giving warm-up, aerobic training, resistance training, balance training, then cool down. My advice is to give aerobic training alternate days and resistance training alternate days. Balance every day. Balance training every day. So aerobic training alternate days, resistance training alternate days, and balance training. Then you should have a cool down time. Always remember, warm up and cool down are a must when you are giving any exercise for endurance and strength. How do we start? What are the precautions to be taken when you are giving an exercise? Start very gentle. If you have no fever for at least 7 days, as well as no shortness of breath or palpitations or chest pain while walking around in the house, and no swelling of the legs. These are the symptoms which have been given not to start the exercise if you have any of these symptoms. Stop exercise immediately or seek help immediately if you develop SOB, chest pain, palpitations, exhaustion, and lightheadedness or dizziness. Now, the take-home message is complications from COVID-19 can be reduced only by delivering interdisciplinary rehabilitation that is initiated early and continued throughout the acute hospital stay. Point number 1. Point number 2, providing patient family education for self-care after discharge from inpatient rehabilitation at either acute or subacute settings. And the third point, continue rehabilitation care in outpatient settings and at home through ongoing therapy, either in person or via telehealth. Thank you very much, sir, for giving me this opportunity.
Thank you very much, sir. Very informative and helpful for us. So now we are at the final stage of program. I would like to invite Dr. Rajiv Ranjan, State Secretary of IAP Jharkhand, to present vote of thanks. Dr. Rajiv Ranjan. Are you with us, sir?
Good morning. Good morning, everyone. On behalf of the Indian Association of Physiotherapists, myself, Rajiv Ranjan, Secretary Jharkhand State Branch, take this opportunity to deliver the vote of thanks for this event to all the dignitaries assembled here. First of all, I would like to give my heartiest vote of thanks for the chief guest, Sri Uma Shankar Singh sir, who gives time from his busy schedule to enhancement us on this occasion. I'd also like to thank our guest of honor, Dr. Vijay Mishra sir, and our special guest, Dr. Sanjeev Kumar Jha sir, for such a thought-provoking and informative address. You are an inspiration for many of us, sir. I'd also like to thank our distinguished lecturer, Dr. K. Manamali sir and Sunit Varge sir, for an excellent presentation and making this seminar very meaningful and interesting. We have learned something which will improve our day-to-day life if we incorporate those. It has been a pleasure listening both and a great learning curve. Last but not the least, it has been our pleasure to host all the participants of the event. The participants were very enthusiastic and cooperative. I am thankful to them for coming here and attending the sessions. Thank you. Thanks a lot.
Thank you, everyone. So we can close the program now. See you all in some other wonderful programs.
Okay. Thank you, everyone. So Now we will leave the program.
Thank you, sir.
Thank you, sir. Thank you very